Feel free to go right ahead.
Hi, everybody. Can you guys hear me okay? Got a microphone? Oh, okay, I'll hear.
I think it's movable. No, we can't. No, they only have this microphone in here, unfortunately. But just kind of talk.
Oh,
Yes.
that works. Okay.
This is, yes, very portable.
Oh, okay, that's probably better. Well, this is amazing. I had no idea what to expect, so I thought there was going to be like 5 people here. So,
No, this is a very popular topic. Everybody loves to hear.
so I'm really excited. I'm so glad you guys are here to learn about a topic that's very near and dear to my heart, osteoporosis. And so, thank you guys all for coming. This is definitely an honor, so thank you. All right, so, I'm Dr. Carolyn Nelson. I'm a board certified endocrinologist, so, and if you guys have any questions after, I'd be happy to answer, okay? Okay, so I'm gonna talk about osteoporosis today, and it is a very underappreciated disease. It is a chronic disease. A lot of people don't even know that they have it, and so that's why I chose this topic today. Okay, so what is osteoporosis? So it is essentially very weak, brittle bone. So bone is living tissue. It is constantly building up and breaking down. And so whenever the breakdown of bone exceeds it being able to be replaced, that is when you get osteoporosis, okay? And why we care about osteoporosis is because it leads to fractures. And fractures can really impact somebody's life significantly. So this is why it's very important. It's the most common bone disease in humans, and it is a major public health issue. And I put this slide up here because it shows the architecture of a normal bone up here on the left, and you can see how thick it is and dense. And then there's an osteoporotic bone there, and you can see how the architecture is affected, and this is going to make you more susceptible to a fracture. So there are 9.9 million Americans that have osteoporosis, and 43 million actually have low bone density. So you've probably heard of osteopenia. So that is kind of a pre-osteoporotic condition. And that is something that really needs to be watched because it can lead to osteoporosis in the future. And this is a very, very frightening statistic, but 1 out of every 2 Caucasian women will experience an osteoporotic fracture in their lifetime. And that is 1 out of every 5 men. And more than half of women aged 75 and older actually meet criteria for osteoporosis. So, and you may not even know. So this is definitely, something that I like to make aware for everybody. Okay, so fractures. So that's the big deal, right? That's why we like to screen people for osteoporosis, because we want to prevent fractures from ever happening. So annually there are 2 million fractures attributed to osteoporosis, and the annual cost of caring for osteoporotic fracture exceeds the annual cost of caring for breast cancer, MI, or stroke in women aged 55 years and older. And this is something that a lot of people don't know as well. Any fracture in a person greater than 50 years old, so we can consider that an adult, at any major skeletal site is significant and should prompt evaluation for osteoporosis regardless if trauma was involved or not. So what ends up happening most of the time for me is I'll go in the room to see a patient for maybe diabetes or thyroid, something completely unrelated, and I'll see that they're in a wrist splint. And I say, oh, what happened? And they fell and they fractured their wrist. To me, that's a red flag. That's, oh, you most likely have osteoporosis. This is a sentinel sign. And I'm like, when was your last bone density? Have you had a bone density? And so then we start talking about those types of things. And the most common fractures are going to be in the spine, the hip, and the wrist. Things that don't count, we don't count fingers and toes and face or skull. those things don't count. So if you've had a fracture there, it's okay, you're fine. So, specifically hip fractures, so those are associated with 8 to 36% of excess mortality, which is death, in 1 year. And some of those statistics are even higher. If you look at other studies, it can be up to 70% mortality in 1 year. And this is going to be higher in men than it is in women as well. So hip fractures are, so if you have a hip fracture, first of all, that's automatic osteoporosis. That's a diagnosis. I don't even need a bone density scan to tell me you have osteoporosis. So if you've had a hip fracture, you have osteoporosis, and this needs to be evaluated. It is followed by a 2.5-fold increase in risk of future fractures. So if you've had a hip fracture, you're 2.5 times more likely than somebody who hasn't to have a repeat fracture. And 20% of hip fracture patients require long-term nursing home care. So, and that is something else that's pretty significant, because especially if you were independent at home, you know, you weren't having any problems, and then you have a hip fracture, you know, 20 out of 100 people are going to require long-term nursing home care. And only 40% of people that have a hip fracture regain their full pre-fracture level of independence. So now, so that was talking about hips. Now we're going to talk about the spine, which is another major site of fractures. So most of these actually are silent. So people don't even know that they've had them. So another thing that I see sometimes is I'm looking at an image for something else, and I'll see that they'll mention in a prior image, like a CT scan, that there's a compression fracture. If I see the word compression fracture, you have osteoporosis, you need treatment. So I may be seeing for another reason, and then I'm like, oh, well, you also have osteoporosis. We need to work this up and start managing this as well. They can be actually associated with a lot of pain. So if people have pain in your spine, like if you have sudden pain in your spine, you can't keep it to yourself. You should tell your doctor, because there needs to be an x-ray done to make sure you don't have a compression fracture. Deformity, disability, mortality, all of these things can be associated with spine fractures. And of course, if you're having postural changes from kyphosis is when you start to bend like this, you know, that is a sign of osteoporosis. That can limit your activity, including bending and reaching. So that, you know, can interfere with your quality of life as well. And if you have a spine fracture, you're five-fold risk of subsequent spine fracture. So you're very, very high risk for repeat fracture if you've had a spine fracture. And you're 2 to 3-fold risk of getting that in other sites like the hip. So if you have a spine fracture, you know, that means you have osteoporosis, but also that tells me you need treatment right away. This is very severe. And then other things that can come from, you know, fractures, of course, can lead to depression and low self-esteem. Again, that loss of independence that you have, feeling like you need to depend on somebody else, it really takes a toll. Okay, so these are some risk factors for osteoporosis or for fracture, for both, okay? So as we get older, that's the number one thing. So if you have low bone mineral, like osteopenia, low bone mineral density, you know, you're at increased risk of fracture. Smoking really increases your risk of fracture. Postmenopausal. So we know that once you go through menopause, the bone starts changing. You're going to be at higher risk of fracture. And in men too, hypogonadism in men, so low testosterone, that can put you at risk for osteoporosis and fracture. Alcohol abuse, lack of physical activity. So I really like to talk about in my clinic about weight-bearing exercise, so walking, riding bikes, things like that. Anything that puts stress on the bone, that's going to encourage the bone to turn over and build new bone, which is what we want. So physical activity is very important to prevent getting into the osteoporotic point. Rheumatoid arthritis. We know this increases your risk, not only just having rheumatoid arthritis, but also usually that requires a lot of steroids, Steroids we know affects the architecture of bone as well and promotes osteoporosis. So this is why as an endocrinologist, I hate steroids. I'm not a fan of steroids, but if you need them, you need them, right? But there should always be a plan. If somebody's starting you on a steroid, what is our plan to taper this off? Because long-term steroid use, that's a whole nother topic, but is not good, okay? Okay, low calcium intake, vitamin D deficiency, a family history of osteoporosis. So one of the questions I ask when I'm seeing a patient for osteoporosis is, did any of your parents break a hip? Or did any of your parents have osteoporosis? If the answer is yes, that puts you at higher risk for osteoporosis. Anorexia, so eating disorders, and also just malabsorption disorders can put you at risk. Steroid use, which we already talked about. Just being thin, so having a thin body habitus puts you at higher risk of osteoporosis and fracture. And other diseases like hyperthyroidism, I always do a secondary workup when I see somebody with osteoporosis just to make sure, okay, is this just age-related or is there another reason why you could have osteoporosis? If it's a young woman, of course, somebody premenopausal or a man, always secondary workup, but I always work everybody up to make sure that I'm not missing anything and that this is just age-related osteoporosis and not secondary to anything else like overactive thyroid or Cushing's disease, which is steroid excess. And falls are definitely going to put you at risk for osteoporosis. So I always ask about falls when I'm seeing a patient for osteoporosis workup. If they're falling, I do refer them to physical therapy for balance issues. So if you are falling too, I ask about these things in the home. Are there any loose rugs that you could trip on? Maybe you need help when you get up out of chairs or in the bathroom. Can you see okay? How's the lighting in your house? If it's low, then you're going to be at more risk for fall. Any obstacles in walking paths like shoes, things like that, where you could trip. You need to make sure all the walking paths are very clear and that if there are rugs, that they're not going to come up and trip you. Any slippery conditions. And of course, too, going through, if you're feeling groggy and sleepy, maybe we need to reevaluate the medications that you're on and make sure that there's nothing that's causing you to be groggy, like gabapentin or something like that, especially in high doses to where you would feel very tired and might, be sleepy. Poor vision. If you've had a fall, you're probably gonna fall again. Depression, dementia, heart arrhythmias, poor balance, and just deconditioning in general. These are all risk factors for falls, which could result in a fracture. Okay, so how do we screen for osteoporosis, okay? It's called a DEXA scan or a bone density scan. It's very low, it's an x-ray, but it's very low radiation, so don't even worry about that. It's very low. It's less than what you would just get exposed to in your normal day. So it's the best diagnostic tool for osteoporosis. And what it's going to do, it's going to send us a report, and it's going to report something called T-scores and Z-scores. So if you guys look at the report yourself, you're like, what is all of this? But these scores are really important. What I look at in postmenopausal females and older males is something called the T-score. And what that is doing is it's comparing your bone density to somebody in their 30s in your same sex. And then the Z-scores, that's usually for the younger population that may have like ulcerative colitis or something, and that is going to be comparing to their age and sex matched person. So, but what I look at most of the time is going to be the T-score. And if it's greater than, if it's less than negative 2.5, that is a diagnosis of osteoporosis. So why do we get these? We're trying to predict your fracture risk. So we want to make and we can also make the diagnosis saying, okay, yes, you have osteoporosis. So we can confirm osteopenia. We can also say, okay, yep, you have osteopenia, not osteoporosis. And another, I think I talk about this in the future, but Something that will come up with that is, okay, say you get a bone density scan that says you have osteopenia. Can we be done with that? No, you can't. Then you have to calculate something called a FRAX, which is your risk of fracture in 10 years at any major site or the hip. And if it's high, then that actually says you don't have osteopenia, even the report is saying you have osteopenia, you actually have osteoporosis. And that I see missed all the time. You can follow, so it's for screening, right? So we're following what your bone density is doing over time. Is it getting worse? Is it getting better? What's going on? So evaluating skeletal effects of medical problems. So this is kind of going back to hyperthyroidism or Cushing's or some other endocrine disease or non-endocrine disease that could be affecting the bone. And then from there we say, okay, is it time to treat? And then this can also, encourage patients to begin therapy. A lot of the times people are very hesitant to begin therapy, but if I can show them, hey, this is your bone density, this is what it was 2 years ago, this is what it is now, sometimes I can convince them to start therapy. And then we can also monitor the response to therapy, which is really important, because you want to see your bones getting better on therapy, not worse. If it's getting worse, then we have to think, okay, is this working, compliance, that type of thing. And then of course saying, okay, your bones are getting worse, are you taking your medication? Sometimes you don't because it's a once a week medication, so that's one medication. So then people was like, okay, I'm not taking it. And I'm like, okay, well your bones are getting worse, do you want to take it or should we switch you to something else? So only 23% of women age 67 or older who have had an osteoporosis related fracture receive either a bone mineral density test, that's the DEXA test scan, or a prescription for a drug to treat osteoporosis in the 6 months after the fracture. So you can see people are not getting treated for this, and it's causing a lot of problems. Okay, so this is where I was talking about the FRAX calculation. So sometimes, you get a bone density back and it says osteopenia, right? And you're like, okay, I have pre-osteoporosis, but I actually don't have osteoporosis. We can't stop there. There is a calculator, it's called FRAX, and what it does is you put in a bunch of details based on the person, and it calculates their risk of fracture in 10 years at the hip and any other major site. And if it's over a certain percentage, you don't really have to know those, that's okay. But if it's over that, it actually tells me, even though it's saying you have osteopenia, you have osteoporosis, and we need to treat you like you have osteoporosis. So that's not something you guys have to worry about. This is what your primary care doctor or an endocrinologist like me will calculate and decide, do you need treatment, even though it's saying you have osteopenia, okay? All right, and so these are this is recommendations, okay? So when do you get a bone density scan? If you're a female, you get it at 65, okay? If you're a man, you get it at 70. That's for everybody. Now, if you have risk factors, I'm gonna get it earlier than that. So you do have to screen for risk factors for osteoporosis. For instance, if you were on steroid for a very long time, I'm gonna screen you before you're 65, okay? So this just says postmenopausal women and men aged 50 to 69 with risk factors. And then postmenopausal women and men, excuse me, age 50 and older who have had a fracture. Sorry. So, like I was saying, if you have had a fracture, like maybe a wrist fracture, and you have not had a bone density scan, you need one, okay? So I'm not just gonna say, oh, well, you're not 65 yet, I'm not going to get a bone density scan. No, I'm gonna get a bone density scan, okay? So vertebral imaging. So another thing that I do is, say somebody comes in, sometimes I just get a lateral spine x-ray to check the spine. So say you're like, okay, I can say, how tall were you when you were younger? And they say 5'9". How tall are you now? I always measure everybody in my office, okay? I think Thank you so much. My mouth got so dry. All of a sudden. Okay, so you were 5'9", and now I measure you, and you're 5'8½". And they didn't even know, because they were like, I'm like, well, have you lost any height? And they're like, well, I didn't think so, but actually I've lost an inch or a half an inch because I used to be this, you know. Then I'll consider, especially if they've had any pain in their spine, just getting a lateral x-ray to check for those vertebral fractures. Because if you've had a fracture, even if I know you have osteoporosis, you're at a much, much higher risk of getting a repeat fracture. Remember, if you have a spine fracture, you're 5-fold more likely to get another fracture in your spine. So I'll get an x-ray just to make sure that there's no fractures, compression fractures in the spine, okay? And this is actually the recommendations is in all women age 70 and older and all men 80 and older, if their bone mineral density, remember we talked about those T-scores, are less than 1 anywhere, essentially, at the spine, hip, or femoral neck. That's a recommendation actually just to get it. So, and then in women age 65 to 69 and men 70 to 79, if the T-score is less than -1.5 at the spine, hip, or femoral neck. And then also in postmenopausal women and men age 50 and older with risk factors, and this is where you kind of think, okay, should we be getting this? Long-term steroid use, height loss greater than 1.5 inches, low trauma fracture during adulthood. So, you know, you can consider getting in all of those cases. I get them pretty frequently just to make sure. Yeah?
What is the neck?
Oh, sorry, femoral neck, that's the hip.
Oh, okay.
Yeah. So,
I thought
well, total hip. Well, they measure two different things. They measure the bone density in the hip, and they measure the bone density in the femur head. So this is like the hip joint, and this is the leg, and there's the femoral head there, and it fits right in there. So whenever they report the bone density scans, they will report all 3 of these to me, and then if I ask for a different one, because there is something also called the distal radius here. So for instance, if you've had a hip replacement, say you've had both hips replaced, I can't see your bone density in your hips. So I'll ask for the 1/3 distal radius here, and they'll do that too, and they'll tell me, do you have osteoporosis here? Okay, so yeah, but those are the 3 sites that you're gonna see on the bone density scan most of the time. Sometimes there's an extra one, and sometimes some are missing for several reasons. If you have scoliosis and you had huge spine surgery, they're not gonna measure the bone density in your spine. So there's several reasons why you wouldn't see some of those on a bone density scan. And you can always ask, okay? Be like, well, I didn't see my spine on there, why? They'll tell you, okay? Okay. So how often do we get the bone density scans? So Medicare is gonna say every 2 years. So I get them every 2 years, but there are some exceptions for that. So if there's an exception and I feel like I wanna get one, then I'll get one. For instance, there's a medication called Evenity. When you're on that for a year, you're allowed to get one after that completes. So I can get that after a year. So it doesn't matter when you had your bone density, once you're done with the Evenity, I can get it. So there are some exceptions, but most of the time it's gonna be every 2 years. So you guys, I want you to think about the last time you had a bone density, and if it's been more than 2 years, you're due for your bone density, okay? So you need to reach out to your doctor. Okay, well, how do we prevent it? Okay, so calcium and vitamin D, those are the building blocks of our bones. So just taking calcium and vitamin D is not gonna prevent it, but it can really help because your bones rely on that. So the skeleton, it contains 99% of the body's stores of calcium. So if you're not taking enough calcium, where's your body getting it to maintain your calcium levels in your blood? From your bones, which is not good for your bones because now your bones are suffering. So that's why making sure you're taking in enough calcium is really important. I usually recommend for all my patients, at least 1,000 milligrams a day. And this cannot be all at one time, okay? You cannot absorb more than 500 milligrams of calcium at one time. So if you're taking all of your calcium at one time, you're not absorbing it. You're only getting 500 milligrams. So it's where are the other milligrams coming from? You know, so then I always say you can get it in your diet too. There's a lot of calcium-rich foods. So I say if you're not gonna take a supplement, then you need to get it in your diet. And so I always say you need to be eating 3 servings of calcium every day. Yogurt, cheese, milk, you know, it doesn't have to be dairy. Almonds have calcium too. So vegetables, those things, so those can really, really help. So it's recommended 1,000 milligrams a day for men, 1,200 for women. So 1,200 is fine. You don't need more than that, okay? So I usually recommend about 1,000 for everybody. And then vitamin D supplement, your doctor's gonna tell you how much to take, but generally 800 to 1,000 international units, that'll be enough for most people.
If you take vitamin D, should you also take K2?
Vitamin K?
Oh, no, it says,
K2.
it just says K2.
I don't think so. I think, yeah, for your bones, I don't think you need that. K2, I wonder if they mean D2 instead of D3.
The challenge you have is you're following up to a lecture we had several weeks ago, and he was talking about the importance of getting D3 plus K2. He says you needed the K2 to absorb the D3.
Right.
Yes.
So, like I said, you know, we're following up lectures.
Okay, no, that's a very good question. You know, I'll have to look that up. So I have never heard that before. So it makes me wonder, unless this is very, very, very new, I don't think that's the case. So you need vitamin D, but I don't know. I'll look it up because I have to look up K2. I don't even know what that is. But you need vitamin D to absorb calcium. So if your vitamin D is low, doesn't really matter how much calcium you're taking, you're not going to absorb it. So that's why, I mean, I always check a vitamin D level in my osteoporosis workup because I want to make sure you have adequate vitamin D. You know, I would consider myself a vitamin D expert, and because I do a lot of mineral metabolism, I've not heard of K2, so I will have to look that up. And I will get back to you guys, because I don't want you to, but yeah, I don't know. I don't know if he works for like a supplement company, I'm just kidding. But I'll have to look that one up, but that would be completely separate from not being able to absorb the calcium from your gut. So.
It's not calcium. Again, it's the D3 that you're trying to get absorbed by.
Oh, well, yeah, there shouldn't be a problem. Unless you have a malabsorption issue. So, for instance, I see people who have had pancreobiliac diversions or some form of gastric, it's a very complicated form of gastric bypass, even gastric bypass. If you have an absorption issue like celiac disease or something like that, then you probably will have some issues absorbing the vitamin D, but just because of lack of K2, I don't even think that's that's not even a supplement we measure, so I would just have to look into it. Yes?
The vitamin D that I get, I mean, the calcium tablets I get have the vitamin D in it.
Yeah,
It's
so
not separate.
that's
And
okay.
You're talking about the K, I know I'm on blood thinner,
Mm-hmm.
and sometimes they'll tell me to eat broccoli because it has K in it.
Well,
So
I think this is different, because I was talking about vitamin K, but they're saying it's different. So I don't know. I don't know if they're talking about vitamin K itself, which you don't need to absorb vitamin D. So, but you will not be able to absorb vitamin D if you have, or sorry, vitamin K if you have a malabsorption problem.
It says online about
Didn't think you were going to get ambushed, eh?
I don't even know what they're talking about.
Okay. So yes, so there is actually new research out that shows, this is why I don't say you need to take more calcium than what I recommend, is because we know that increased calcium can cause coronary artery disease because it will go deposit in the arteries. So this is actually probably very new. And it sounds like it's not an issue with absorbing the vitamin D from your gut. It's just making sure that the calcium is going to your bone and not to your arteries. Which this is probably very new actually, and I'm glad I've learned something today. So this is great. And so I'm gonna look into the K2 and see if I need to start telling patients to take that. But this is why I actually don't recommend higher than really, I recommend 1,000 milligrams a day. And remember, you have to divide it into different doses. Okay, and if you have the vitamin D and your calcium, that's totally fine. I always just say, if you come to see me, bring in your calcium and vitamin D. Because a lot of the times, you don't know how much you're taking, you don't know how much is the milligrams, and I always like to look at the serving size too, okay? Because sometimes it'll be 2 tablets have 500 milligrams, and most people are taking 1 tablet, so that's only 250 milligrams, right? So they think they're taking 500. So always look at the serving size and how much milligrams it is, and then remember, you divide it equally twice a day. Now, if you get a lot of calcium in your diet, then maybe you only need 1 supplement. So you just need the 500 milligram, the other 500 you're getting in your diet, okay? So again, you don't need to go over 1,200, and the risk is for the coronary artery disease. That's why we don't like to go over that. You don't need more. It's not like it's gonna be better for your bones, okay? So I just put this up here. A lot of people forget that Tums is actually a good source of calcium. It's calcium carbonate, so it needs to be taken with food. So there's 2 different forms of calcium. Calcium citrate, that one you can take anytime, doesn't matter. And then calcium carbonate, which is like Tums. And so that needs to be taken with food to absorb. Otherwise, you don't absorb it. So if you eat Tums just by itself, you're not eating with food, you're not getting that calcium, okay? So that's a really important point I always like to tell my patients as well. And then vitamin D3. So this is the over-the-counter vitamin. If you have really severe vitamin D deficiency, sometimes I prescribe a vitamin D2 once a week for a certain amount of weeks, usually 8 to 12 weeks. And then I transition them to the over-the-counter vitamin D3. And that's just to boost your vitamin D and then maintain it. Okay, and in my clinic, you know, I have a lot of people who can't tolerate calcium for whatever reason. So I actually have a list kind of like this one here, full of calcium-rich foods and how many milligrams is in it, so that they can instead get their calcium from their diet, which I always prefer anyway. So I have a whole sheet like this that I give them so that they can start putting some calcium-rich foods in their diet. Okay, so how do I treat osteoporosis? So the first visit, I gather a lot of history, okay, and I try to see where are we in your risk. And then I obtain lab work, and I do a secondary workup if needed, and if I need to, I also get a more recent bone density and perhaps a lateral spinal x-ray, okay? And then the second visit, I bring you back and we go over all of those things. And then I decide, we talk together, decide what medication we want to start for osteoporosis. There's several medications for osteoporosis. The first one that I have listed up there, raloxifene, is a very weak, what we call anti-resorptive, or almost like bisphosphonate. So you've probably heard of Fosamax before. You probably know somebody on Fosamax. So that is what we call an anti-resorptive. So it prevents the bone from breaking down. So that's its job. So in doing that, it's supposed to make your bone stronger. So it is a very good medication. However, it's an oral medication that you take once a week. And if you have acid reflux, it can be very bothersome to the esophagus. You have to sit upright. You have to take it on an empty stomach. You have to sit upright for 30 minutes. You can't eat or drink anything, and again, it's once a week. And so if you're not taking it, it's not gonna work, right? So that's probably my least favorite, but it does work for a lot of people. And so if you take it every week, it's not a big deal, and it will help you because it's a great drug. Same thing with the Actonel. Boniva, and then in that bisphosphonate group 2 is something called Reclast. So that is an IV infusion. It takes about 30 minutes in total to have that done, and it's only once a year. So I use this medicine a lot because it's a once a year infusion. It's the same thing as Fosamax, but it's just once a year. And we do that for 3 years. And then we monitor, we get, bone density scans, and we see, how are you doing? At the end of those 3 years, I have to decide, do you need a little bit longer? Because I will go to 5 years. Should we switch to something else? So Fosamax, that's gonna be about 5 years. And then what they say is after 5 years, you consider something called a drug holiday. A drug holiday is a recommendation, it's a suggestion, it's not definitive. So if you still have osteoporosis, I don't recommend a drug holiday. I keep going, but maybe I switch you to something else because you need something a little bit, that works a little bit better. And then another anti-resorptive is Prolia. So I'm sure you guys have heard of that one too. That's an every 6-month injection. This one is lifelong though. You can't, it's not like you can stop this one. If you stop Prolia, your bone density will fall significantly. So, whenever I tell my patients, you have osteoporosis, I always like to say, this is a chronic disease, okay? It's not just gonna go away. It's kind of like high blood pressure. You may not know it's there, but it's there. And if you don't take your medicine, it's something, something bad could happen, So with Prolia, it is lifelong, it's every 6 months, but I always say this is a chronic disease and this is the treatment for your chronic disease. So if you ever want to come off of Prolia, you have to talk to somebody first, either an endocrinologist like me. You can't just stop it, because if you stop it, you're going to lose everything that you gained and probably fracture, okay? So there's a special way that we take people off of Prolia. Now, if you had more than 3 injections, this is where it becomes a problem. If you had 1 injection and just stopped, that's okay, okay? But this is why, Prolia, I tell everybody, this is a lifelong. You can't just stop it. If you have to stop it, you need to talk to somebody first, okay? That's a huge take-home point. And then my favorite group, we have the anabolics. So these are bone building drugs. So they actually build the bone. I usually, if I can, start with this, and it depends on the severity of the osteoporosis. Most people do very fine with just an anti-resorptive, but the anabolics, you're gonna get the biggest increase in bone density from taking an anabolic and then following it with the anti-resorptive, okay? There's many studies on this now. Unfortunately, a lot of insurance companies don't cover them, so sometimes our hands are tied. But if I have somebody, for instance, who has had a previous fracture, I always try to get an anabolic first, okay? So the newest one is called Evenity. So that is a drug that is an injection. You get an injection in each arm once a month for a year. You're not gonna get any better benefit after a year, so after a year, I switch you over either to Reclast or Prolia. That's how I do it most of the time. Fosamax would be fine too. So again, I don't like to use a lot of Fosamax because I've seen too many people not take it. So, but it's still a great drug when you take it. So, and then the other one that I use a lot is called Tymlos. So with Tymlos, you're gonna have better gains in your spine than you are at the hip. You're still gonna have some at the hip, but it's not gonna be as great. So if you have a hip fracture, I prefer Evenity. But with Tymlos, you can still get some hip benefit, but mostly you're gonna get a lot of benefit in the spine. So if you have a spine fracture, Tymlos is great. Tymlos and Forteo are very similar, but I don't use a lot of Forteo because it's not as easy to get as Tymlos. So I don't use Forteo too much. For a while, Forteo was covered in men only and Tymlos wasn't, but January 1st, Tymlos is now covered in men, so I'm very excited. I have 2 men on Tymlos now, actually. So Tymlos and Forteo, they're both daily injections for 2 years. So that's kind of the harder sell, but once they know how good their bones could be, sometimes it's not that hard. Because then they'll take it. And then again, anything in the anabolic category, so those 3 drugs need to be followed with an anti-resorptive, okay? So if someone has said, oh, I've already taken 2 years of Forteo, sometimes I get that. I'm like, well, what did you take afterwards? Nothing. That's not good, okay? So it's like almost a few years later, not taking anything, okay? So what you build, you need to maintain, okay? And so that's why we do the bisphosphonates followed, or the anabolics followed by the bisphosphonate, okay? And the timing of that, you don't have to worry about, that's what your doctor's there for, okay? Now, I'm going back to the raloxifene because I realized I do like to talk about the other 2 first. That one I rarely use. It's a very weak bisphosphonate, but it does have one role where I would use it. And it would be in maybe a woman in her 50s who has a high risk of breast cancer. In which case, so I have one patient on it because she is in that category. She has like very mild I think she has osteopenia with a high frax. So I put her on raloxifene because her mother had breast cancer. And then when I follow her bone density up, I may switch her over. It depends on what her bone density looks like. If it's improved a lot, then great. If not, I'll probably end up switching her. But she has, you know, a high risk of breast cancer, and she's young, so I did put her on raloxifene. But for the most part, I only use the other medications, okay?
I got a question.
Yeah.
I was on the hormones, and then the study said we're taking you all off, and then we were put on a Vista.
Mm-hmm.
So I'm still on a Vista after a number of years. Of course, the problem with the Vista was that you were on the hormone sometimes for hot flashes, and the Vista kind of helped you keep some of those. But you're saying, which I have maybe some osteopenia, what should we be taking now?
Well, that depends. So remember, the only indication for hormone replacement therapy post-menopausal is debilitating hot flashes, okay? So if you don't have hot flashes anymore, then the question is, and you have osteopenia, do you need the raloxifene? Probably not. So that would be something to talk with your OBGYN, whoever prescribed it to you, I'm assuming it's your OBGYN, about, and if you even need it. Because if you're not having hot flashes anymore and they're monitoring your bone density, you probably don't need it. Now, it's not hurting you, and it's probably helping your bones, but if you can cut back on a drug, then a lot of people would like that. So I would say you probably don't need it, okay? And then, yeah, if you have hot flashes, then, and they're bothersome to you, then talking about either, you know, an estrogen patch, most likely, is what I would go with.
Okay.
And if you still have, well, we can go into a lot more detail, but yeah, so that's like hormone replacement therapy. So another thing I see a lot is women who went through menopause very early, so early menopause, either surgical or, you know, for another reason, they went through menopause in their 40s or in their 30s, and not put on hormone replacement, that's gonna increase your risk of osteoporosis significantly too. So that's why I always am like, did you have your ovaries removed? If they say yes, then that means they went through menopause, and they went through menopause early, which is a risk factor for osteoporosis, okay? If you don't get the hormone replacement that you need. Okay, so this is the big one. So drug safety. So everyone that I see, most of the time, is very scared to start any treatment. But the benefit of the medications that we start strongly outweigh the risks, okay? So what I do on an initial visit is I always look in the mouth and I see how your dentition is, and I always ask, are you seeing a dentist regularly? If the answer is yes, and your mouth is well taken care of, and you're not planning to have any extractions or implants, the risk of osteonecrosis of the jaw is so small that it's almost not worth mentioning, except for it's a black box warning on there. So, or it was, I think they've finally taken it off. But, you know, that's what everyone gets very excited about and nervous about. But as long as you're getting your regular dental exams, you really don't have to worry about it, okay? So it's something that's there, it's a risk, but as long as you're being monitored and you're not planning on like extensive dental work, then it's a very, very low risk, okay? Whereas your risk of fracture is very high. So that's why we always kind of weigh risk versus benefits, and the benefits of these osteoporosis medications really strongly outweighs the risk. The other one is something called the atypical femur fracture. So this would be kind of a deep groin pain that you would feel usually in your bilateral groin area. Most of these would occur with long-term anti-resorptive use. So this is long-term bisphosphonates, okay? So how long to keep somebody on these medications, you know, we don't really know. And that's the hard part. And that's what, you know, I think confuses a lot of the primary care physicians, because what they'll do is they'll say, oh, you've been on Fosamax for 5 years, you're done. And then that's the end of it. But what if you still have osteoporosis? Or what if you fracture after that? Like, what do you do, right? Those are all the questions that I think doctors get confronted with and they're not sure what to do. And so that's when, you know, they should call me, you guys should come see me, because I can definitely help there. Because while we don't have a lot of data on that, there are things that we do, because if you have a fracture, especially after bisphosphonate use and you haven't been taking it for a while, you still need treatment, okay? You're really high risk of fracture again. So, but the atypical femur fracture, again, is very rare. It's like 1 in a million, okay? But it can happen, especially with these prolonged anti-resorptive use like Fosamax. So that's why I really don't like to use Fosamax for longer than maybe like 7 years is how long I would probably use them. And then at that point, I would switch you to something else, probably Prolia, okay? Yeah, again, these are usually seen with the long-term use of anti-resorptives, okay? And Prolia, not necessarily, so these things can happen in Prolia too. Again, they're really rare, but there's something that I always talk about with my patients, so that, hey, if you're having significant jaw pain, if you have deep bone pain, especially in your groin, you have to let me know. You know, don't just sit on it, because we need to see what's going on. Okay, and I think that's all I have. So if you guys have any questions, I'd be really happy to answer. Yes?
Have you learned, or do you know of any correlation between taking Nexium and Prilosec and it causing or resulting in increased chances of getting osteopenia? The reason I say that is I was on heavy doses of Nexium and, you know, in the past, and now I have osteopenia.
Mm-hmm. I think where that probably would be a concern would be with the absorption of calcium, perhaps. And then also if you were ever taking, not for you, but if you were ever taking like a bisphosphonate, an oral bisphosphonate with that, what would happen, right? So you shouldn't take it with that. But I don't know. I would have to look and see if that would be like a risk factor for taking Nexium. Yes.
What would you recommend to someone who is reluctant to take the meds due to the side effects?
So that's always the hard part, right? Is trying to convince someone to take the medication. So I'm hoping that after seeing the presentation and just how high the risks are, or how high the benefits are and how low the risks are, that you would at least try something. So I convinced someone to try Temlos, but she developed headaches on it, and so we did have to stop it. But I did switch her to something else, and she doesn't have any problems. So yes, there are always a risk of developing a symptom, but just trying it and just knowing that taking 1 dose of it is probably not going to do anything, you know, that's gonna really harm you. It just won't, okay? And so I would try it, I really would encourage you to try it and just see how you feel, okay? A lot of the times, these drugs have 0 side effects. So as long as you're being monitored, now I don't want to say take a Lindronate and then just go off into the world and never get monitored, never have a repeat bone density, things like that. But I would of course strongly encourage you to take these medications just because I know all the negative things that can happen after a fracture, and I've seen them all. So, I had a lady come in to see me who had 10 compression fractures, and I could not convince her to take anything. And it was actually really sad. And she was in so much pain, and she's wearing a brace, and it was just heartbreaking that she even got to that point without any treatment, because she had never been on treatment. But unfortunately, I couldn't convince her. So, that's honestly probably the hardest part of my job, is trying to convince people to take the medication. So, but I would say try it and just see how you feel. If you have a negative side effect, there's alternatives, So, and again, maybe Fosamax would be a good idea because it's something you can do at home. It's once a week, you don't have to go anywhere. So the other medications like Evenity and Prolia, in reclass, we do them at infusion centers. So, so some people like the no hassle of the Alendronate or the Fosamax, but again, if you're taking it, that's the only way it's gonna work.
Thank you.
You're welcome. Yeah.
Do you know why primary care physicians or any doctors that I'm aware of are trying to push men, you said at age 70, to get DEXA scans or to take calcium? And we hear it all the time about women, they'll get your DEXA scan every other year. But my father died he's almost 94 from a fracture in his hip.
Yeah.
And he'd had several other fractures before that. And he was never told, let's just go get DEXA scan. All I got when I asked about it was the nurse was kind of nasty and said, well, it's obvious. But the DEXA scan shows how much, right?
Well, so your dad obviously had significant osteoporosis, okay? I don't need a DEXA scan to tell me that.
Yeah.
So, and your question is a very good one, and I think it has to do maybe with, I don't know if it's lack of maybe education or just like maintaining education. I wish I had an answer for you. I wish nobody came to me with fractures and things like that.
Yeah.
But yeah, I think it's just, as doctors, I think we need to do better, especially with osteoporosis. That's why I wanted to actually give this talk today, because I was hoping that maybe it would inspire some of you to be like, when did I last have my bone density? Because maybe your doctor has not brought it up in years, which I have seen. So, and that's terrible on our part, okay? That should not happen. That's why you come to see us, so that we can help you with these things. But, there's a lot of like system issues in healthcare where, like for instance, I've seen people have hip fractures and they'll go to orthopedics and they'll get surgery and all these things, and then they won't see me for years. That should never happen, right? But I think a lack of endocrinologists is a big problem, and just a lack of education surrounding osteoporosis. Like I said, I think it is a very, very underestimated disease, and it can cause so much problems. And so that's why I really want to talk to you guys about it today, because I think it is we know it's undertreated, and I think that we definitely as a medical community could do a lot better.
Well, I mean, at least minimum for men, say you need to start taking calcium and vitamin D. I mean, it's just, I don't see it in
Yeah.
general
You're right. So
literature like it is for women.
yeah,
With
so
the DEXA scan.
you're right. I mean,
Yeah.
it used to be so it used to be everything postmenopausal female, right?
Mhm.
We couldn't even get Temlos covered until this year. So this is 2023 for men, right? So you're right. I think that it's definitely very focused on women, but men get osteoporosis too. So that's why we have these guidelines. So the guidelines say get a bone density scan at 70 unless you have risk factors. If you have risk factors, you should be thinking about it at 50 in men, right? So I have young men, when I say young, I mean, in their 50s, that have osteoporosis from long-term steroid use. If someone's on steroids for a really long time, I'm gonna screen you. I'm not gonna wait till you're 70, you know, and he has actually a compression fracture too, which I found. So, because I did the x-ray. So, yeah. I don't know if I answered your question, but.
It's not right.
Okay, I'll come to you because I think they're done, okay? So I don't want to hold everybody up.
We'll start serving lunch, but thank you so much. And if
Thank you guys so much.
if you have time for a few more questions,
Yeah,
you're welcome.
yeah. Oh, no, that's okay. No, just like halfway through, I was like, oh my gosh, I can't breathe. I'm like, I'm sorry. I was like, hi.